A critically ill patient lies in an intensive care unit. Their vital signs are monitored, fluids measured, and medications titrated to the microgram. Outside this highly controlled environment, a secondary variable is introduced. A group of people, miles away, focusing their intentions entirely on this specific patient's recovery. The clinical question is whether this invisible intervention, remote intercessory prayer, actually alters objective mortality or disease progression when measured alongside standard care. On the wards, spontaneous recoveries often coincide with reports of deep faith and community prayer, but anecdotal observation cannot separate cause from coincidence. To find the physiological truth, we have to look at blinded, controlled data. We need to quantify intercessory prayer. We have to strip away the theology and test it strictly as a measurable medical variable. The standard of proof here requires the same rigor applied to a new pharmaceutical, large-scale, multi-center, randomized controlled trials, and comprehensive meta-analyses. The data we will examine relies on 9 peer-reviewed studies published across the medical literature over the last 3 decades. These trials span multiple pathological disciplines, measuring outcomes in cardiology, oncology, and infectious disease. You can find the full bibliography and access the original papers in the video description to independently verify the data. Intercessory prayer is evaluated here as a testable clinical intervention, subjected to the same evaluative standards as evidence-based medicine. To evaluate prayer objectively, we apply a pharmacodynamic deconstruction. We analyze it exactly as we would a pharmacological agent. Testing an agent requires isolating its dose, in this case, the volume of prayer, and its route of administration, comparing proximal interventions of the bedside against remote intention from a distance. The central biological problem is locating a physiological mechanism of action. Human anatomy must possess a receptor capable of responding to this remote intention for it to work. The ultimate epidemiological test of this dose-response hypothesis is found in a 2021 study tracking the longevity of Roman Catholic bishops. The Roman Missal mandates that during every Mass, specific prayers are offered for the local bishop by name. This means a single bishop receives millions of highly regulated, named individual prayers for their well-being every year. The dose is massive. Researchers compared the lifespan of these bishops against 2 control groups: standard Catholic priests, who receive far fewer prayers, and male academic teachers. This scatter plot of life duration shows data points for priests, bishops, and academics overlapping entirely, with no significant life extension for the highly prayed-for cohort. Next, this line graph of lifespans across 6 nations reveals overlapping standard deviations, demonstrating no geographic dose-response effect. The raw statistical reality is stark. The occupation of being a bishop accounts for a mathematically marginal 0.2% variance in lifespan compared to the control groups. This dataset nullifies any dose-response relationship, demonstrating that even extreme volumes of intercessory prayer fail to alter the trajectory of human longevity. Moving from long-term epidemiological longevity to acute pathological interventions, we find early historical studies that initially suggested a positive effect. This paper, a 1998 study published in the Western Journal of Medicine, reported that a small cohort of advanced AIDS patients receiving distant healing experienced fewer new illnesses and required fewer doctor visits. Similarly, the 2010 STEP trial tested proximal prayer on auditory and visual impairments for a small group of patients at a rural clinic in Mozambique. These early studies fall into a common statistical trap. Small sample sizes inherently generate statistical noise. In underpowered trials, random variation easily masquerades as a positive efficacy signal. To find the physiological truth, clinical testing had to escalate to the high-stakes, objective environment of cardiac bypass surgery. This led to the definitive megatrials in this space: the 2005 MANTRA-2 study published in The Lancet, and the 2006 STEP trial. MANTRA-2 was scaled up significantly, enrolling over 700 patients scheduled for elective cardiac catheterization or percutaneous coronary intervention. The trial used a rigorous 2x2 factorial structure, testing unmasked bedside therapies against double-blinded remote prayer. Findings showed bedside intervention successfully lowered pre-procedural anxiety and subjective distress. However, looking at objective clinical endpoints, major cardiovascular events, and mortality, neither therapy produced any measurable treatment effect. The data draws a hard clinical divide. Psychological comfort is improved by human presence and supportive interventions, but physiological repair is entirely unaffected by them. When clinical trials are scaled up to eliminate statistical noise, the objective reality is that remote intention cannot alter ischemic pathology. Is it possible that different specific diseases, like infections or malignancies, respond differently to intercessory prayer than cardiovascular damage? A 2017 study in the Journal of Religion and Health tested Islamic intercessory prayer specifically on the healing rates of dermatological warts. A 2012 study investigated the impact of prayer on spiritual well-being and disease progression in oncology patients, and a 2023 randomized double-blind trial evaluated the use of remote prayer during the acute clinical evolution of COVID-19 infections. Across all these distinct pathologies, the outcome was uniform. Objective physical healing and disease resolution showed zero statistical divergence from the control groups. The ultimate arbiter of clinical evidence on this topic is the 2009 Cochrane Database of Systematic Reviews meta-analysis. The sheer scale of the Cochrane synthesis provides absolute clarity. By aggregating data from 10 trials encompassing over 7,600 participants, it eliminates the noise of isolated anomalies. This massive meta-analysis definitively accounts for the phenomenon of spontaneous remission within large populations, mathematically smoothing out the outliers. This addresses a pervasive cognitive bias among medical professionals. We have a human tendency to attribute spontaneous, coincidental recovery to a patient's prayers or personal faith, rather than recognizing it as basic statistical probability. The controlled clinical reality reconciles the anecdotal ward experience. Instances of rapid recovery that happen to coincide with prayer are a function of standard deviation, not the efficacy of the remote intervention. The aggregated results of these 9 studies are consistent. Intercessory prayer produced no measurable change in physiological outcomes, disease progression, or mortality rates across any studied population. To lock this empirical understanding into daily clinical practice, we can apply a core mnemonic paradigm. The chart reflects the pathology, not the prayer. In practice, this means a patient's subjective psychological comfort may improve through their faith, but their anatomy remains entirely bound by standard pathophysiology. This leads to 3 actionable rules for clinical practice. Point 1. Maintain evidence-based primacy. A physician must never alter, delay, or substitute prescribed evidence-based medical interventions based on a patient's utilization of or belief in intercessory prayer. Point 2. Delineate psychological from physiological. Recognize proximal interventions like family prayer or therapeutic touch strictly as tools for acute anxiety reduction. They are entirely devoid of curative properties. Point 3. Maintain neutral clinical posturing. Acknowledge a patient's prayer as a valid psychosocial coping mechanism, but do not endorse it as a variable that impacts objective morbidity. Bring this empirical separation of psychology and physiology into your next interdisciplinary morbidity and mortality round. And check the description for our disclaimer and full bibliography.